Welcome to Vision 2020 USA's Spotlight Series. Today's topic, Work with the Navajo Nation, featuring Dr. Robert Hoffman, Professor of Ophthalmology and Visual Science at the Moran Eye Center at the University of Utah, and Dr. Craig Chaya, Associate Clinical Professor and Senior Medical Director of the Global Outreach Division at the Moran Eye Center at the University of Utah. The Spotlight Series is hosted by Dr. Rajiv Ramchandran, an Associate Professor at the Flom Eye Institute at the University of Rochester, and Dr. Dean Van Asdale, an Associate Professor at the Ohio State University College of Optometry, leading members of the Vision 2020 USA Executive Committee.
Great. Okay. Well, we are recording, and I will turn it over to Bob and Craig. Go ahead.
Okay, so it's my honor to introduce my colleague, Craig Chaya. Craig is currently an associate professor of ophthalmology at the University of Utah, Moran Eye Center. He is the medical director of our outreach division. I've known Craig since he was a glaucoma fellow with Alan Crandall. And Craig has, kind of lived doing outreach. He took his family and lived in a resource poor setting and practiced prior to coming back and joining us. He has become a very talented and innovative anterior segment surgeon, and we worked together on, many pediatric glaucoma and cataract patients over the years. And I've had the privilege to travel with him to Ghana and many trips to the Navajo Nation. And Dr. Chaya is going to tell us about our Navajo program in general and give you an overview of what we do on the adult side. Dr. Chaya.
Thank you, Bob. All right, let me just share my screen. Okay, great. Thank you so much for the opportunity to chat with you folks about our program. So just a little bit of background about the Navajo Nation. I think it's important to kind of set the setting and where we are geographically located. As you can see, the Navajo Nation actually encompasses 3 states near the Four Corners area of the Southwest, parts of Utah, New Mexico, and Arizona. And by landmass, it is the largest reservation in the United States, and I believe in North America. It is also the largest by citizenship. Around 400,000 people are registered as Navajo citizens. And the people are known as the Diné. That's the preferred term that they like to refer to themselves as, the Diné. The Utah Navajo Health System is our major partner with delivery of eye care. And UNHS has a history that started in 1999. The Utah Navajo Health Commission recommended that local management be directed for healthcare services. Thus, in 2000, UNHS was established as a 501c3, Utah Navajo Health System. And the Utah Navajo Health System is governed by a board of directors that is 100% Navajo members. And their current executive director is Michael Jensen, who helps to administer the entire program for the Utah Navajo Health System. Of note, the Utah Navajo Health System, their main stakeholders are those individuals that live on the Utah Strip side of the nation, although you can understand that as a member of that tribe, patients move back and forth across state lines. And so many patients do come from neighboring areas, depending on what care is being offered. For example, we have cared for patients who've come from Arizona and New Mexico, but I would say for the large part, most of the patients that we see are from the Utah side of the nation. So our partnership, again, was established in about 2013. And interestingly, UNHS has a contract or an agreement with the University of Utah to expand specialty care. Hence, this is how we got involved in this whole partnership with UNHS. And our group started in 2013, providing pediatric and adult screening, and that continued to expand. Our teams are largely volunteer-based, and it's composed of medical students, community partners, industry partners, technicians, RNs, and ODs and MDs, largely coming from the Moran Eye Center, but we do also get volunteers from other neighboring states, from volunteer adjunct professors, as well as alumni who have been generously donating their time to our program. We provide full spectrum care. That's everything from screening, optical services, surgery if needed, and also specialty care. Most of our surgical services that we offer currently down on the Navajo Nation are anterior segment, cataracts, pterygium-based type surgeries, some minimal glaucoma surgery. For patients that need further level of care or specialty care, those patients are brought up to the University of Utah, where we're able to house them and also provide the surgical services that they need. Our annual budget is roughly $100,000 to be able to conduct our program. That helps us support primary logistics. As you can imagine, we are up towards the northern part of the state, and it takes a while to get our teams down there. These are weekend programs. We have teams that leave Thursday night, Friday morning. And so it does take a great deal of manpower and financing to be able to move those individuals safely down to the Navajo Nation. Our programs consist of roughly 5 to 6 weekend trips, and throughout the year we provide tertiary or triage services. So in case patients are unable to be tended to locally, we can bring them up here to the Moran Eye Center or find community partners that are local in that region to help provide care that they may need. So in 2022, we published a paper on the patterns of blindness on the Navajo Nation. It was a 9-year study looking at this period of time between 2013 and 2021. And we looked at all of our first-time visits of patients who presented to our screening clinics. It was roughly 2,200 patients. And among patients who presented without glasses correction, roughly 21% had mild visual impairment, 9% moderate to severe, and roughly 3% were blind. Of those that were blind, the large majority were due to cataracts, and the rest were refractive error. Among those patients, interestingly, with diabetes, 17% presented already with signs of diabetic retinopathy of different stages. So what does our future direction look like for the Moran Outreach? Currently, what we're involved in is expanding our surgical services. Currently, our surgeries are performed out of a community hospital neighboring on the Navajo Nation out of Blanding, Utah, but we're hoping to expand surgical services more centrally located to our patient population. So we're hoping to roll out an office-based surgery program at their Monument Valley Clinic that you can see here in the picture. In addition, some research projects that we're excited about are a vitamin A deficiency screening project led by my PI, Paul Bernstein, a retina specialist. And this is going to be looking at a unique device that's pictured here called the Vegometer. And the Vegometer is a non-invasive way to measure skin carotenoids as a proxy for what vitamin A levels may be in the serum. So this will be correlated with serum blood draws in order to look at vitamin A levels and see if it correlates with skin carotenoid levels. Paul Bernstein has already conducted this study in Nepal, and we're hoping that the results will be very similar, that the Vegometer will be a very close proxy for vitamin A deficiency. The population that we're looking at particularly are expectant mothers and children. This is I would say, nutritionally deficient area. It's hard to grow food, fresh food in this region. So this is an important topic to look for vitamin A deficiency that may help to shape policy and also shape food services in the area. Finally, we're hoping to become contracted providers. Currently, our work down in the Navajo Nation is all done pro bono and supported by generous donors. But UNHS is a federally qualified health center and has unique status with Utah Medicaid. And what we're hoping to do is become actually official contracted providers so that we can access Utah Medicaid funding in order to make this program sustainable in the long run. So that's a general overview of our Navajo Nation outreach program. Happy to answer any questions.
Thank you for that detailed review of what you guys are doing, and you've been doing this for almost 11 years, looks like. Whenever you build these programs, one of the important things is sustainability. And just could you talk a little bit about how you've made this sustainable over time? What went on into the organization and securing of funding to make this happen?
Yeah, we're blessed with a very generous local donor community that has been passionate about local outreach, particularly post-COVID. And I would say that they are really the backbone of this program currently, but we understand that there are the ebbs and flows of generosity that can occur, and there can also be donor fatigue. So hence, we're moving into a new direction where we're hoping that our services that we're actually providing will be funded by Utah Medicaid. And that will be a much more sustainable way to continue the program long term. Our donors will continue to play a role, and they may be involved in such things as capital expenditures when we need to upgrade our equipment, or if we need to purchase large items like expanding our surgical services on the Navajo Nation. So I would say the other major backbone is our volunteer base. This is a very popular program among our medical students, nursing students, and staff here locally. One thing that we've done to make it, I think, exciting is I think there's a lot of camaraderie built around the program. Often these outreach programs, there are hikes that are planned, social events that are planned around the events. And it's quite a popular time for people to come. It's on a weekend where people generally have free time to come and donate. Otherwise, it's very difficult to travel down to the nation during midweek. So we've tried to plan around that, plan around what our donors need, as well as what our volunteers would wish for. And for many of them, the weekend style of outreach has been very popular to be able to integrate into their normal lifestyle.
We have a question here from Jennifer Leo about the average number of patients per year seen. And do you have a sense of kind of the diagnoses that you're finding, the disease levels that you're finding? I know you presented a little bit about that with retinopathy and things.
Yeah, I would say cataracts and refractive error are still largely what we find to be the major causes of visual impairment and blindness. Bob's going to talk a little bit more about what we see in our pediatric population particularly. And on a given weekend trip, these are 5 to 6 trips per year, we may screen anywhere between, it depends on the season, but 80 to almost 200 patients per weekend. We have a screening session set up on Saturday, and surgical patients range anywhere from 4 to 10 patients per Friday afternoon or Friday morning when we do our cataract surgery campaign. And so it's variable in terms of the number of patients that we screen. Now that's just for our adults. If we combine that with a pediatric vision screening, we're screening anywhere from close to 100 to 200 kids on a Friday afternoon.
And then note you talked about funding. Now, do you get any federal funding for this?
None. UNHS is independent of IHS funding. I think there was a question about IHS funding, and UNHS was set up as a 501c3 that's locally controlled or locally governed by Navajo Nation members. But they do apply for some grants. The entity UNHS does apply for some grants, but nothing that we receive at the Moran here specifically.
Great. And some of our experts at international health here also want to know about your team and your outreach to the various communities. How do you make sure people are coming to your clinic? How do you populate your clinic? And what kind of size of the team do you take down to help?
Correct. So we do have a local person who is employed by UNHS that is our liaison that helps to schedule patients. And they're able to schedule patients using our electronic medical record system, EPIC, which many of you are familiar with. And so UNHS has the ability to schedule those patients into our templates. And we also have representatives in different chapter houses that help to spread the word in terms of when we're coming. We have a calendar that we publish in terms of our times that we're going to be going down for the year. And so the word gets out pretty quickly in terms of those that are interested in accessing our services.
Great. So it's good publicity. That's important to get
Yes.
time
Yeah.
to make
in
it.
terms of the size of the team, it can be anywhere from 20 to 30 individuals that we bring down on a weekend to provide everything from history taking, screening, throughout the entire process, and then our providers, MDs, ODs, to do the actual full exams if needed.
That's great. And, often all these screenings and care delivery, eye care is not just a one-time shot. It's a chronic disease delivery system. So how do you determine follow-up and manage and care for follow-up for this?
Yes, great question. UNHS actually employs, I believe, 2 optometrists that are fully employed by the nation, and they help to provide a lot of the postoperative care and follow-up in between our trips. And if patients are needing to come during times when we're not down there, for critical needs, especially surgical services, then we can bring them up here to Salt Lake City for specialty care.
That's great. And it's a really inspiring thing for those trainees and those new to eye care to be involved. Do you see people continuing this in the future? And is this a pipeline to get more people involved in such type of community service and engaging in underserved populations?
Yeah, we have an ophthalmology interest group here at the University of Utah, and it's heavily engaged with members of their with our ophthalmology interest group. And we also have members of our nursing school that attend regularly. And we have a core group, I would say, stable, long-term volunteers that generate or donate their time.
That's great. And do these students like stay on, you think, or do they know if they go elsewhere and establish such practices, or?
Yeah, I don't know. I don't know what's come of it in terms of downstream effects in terms of other communities around the United States, but I think there is an active level of engagement in terms of how to start programs locally. I think that's one thing that we have tried to inspire our volunteers with, is that it may not require you to travel overseas, that there's a tremendous need here just locally in most of our communities. So for us here in Utah, the Navajo Nation has been a very strong area of need and one that we can easily access.
Great. Well, the questions keep coming here. So there's a question on how many patients on average. I think you're saying 80 patients screened. Now, do you have exams besides the screening as well at the same time, or?
Yeah, so we do have criteria in terms of patients who come in through the screening process. Obviously, those that are diabetic, we dilate all of them. But not every single patient who comes through our screening process is dilated. If patients are generally healthy, seeing well, and just maybe need a pair of readers, those patients may not go through the entire full exam. But we do recommend that they get their regular annual eye exams with the local optometrist. So the screening is really to reach those people that are unable to access the optometrists that are employed by UNHS. And so as we move our sites of screening, they are spread out throughout the Navajo Nation. And so in different locations, we're currently in 4 sites throughout the Navajo Nation, largely on the Utah side. And I would say we screen anywhere between 80 to 150 adults. And then that's in addition to what we do for our pediatric vision screening, which is largely a school-based program that Bob will talk about.
That's great. Any observations have you had on glaucoma, normal tension glaucoma? I guess Dr. Brinks would like to know.
Yeah, there's definitely some glaucoma. It's not as intense as we would have imagined. For example, as if we use an example of our local population here in Salt Lake City among Latinos and our underrepresented minorities here in the Salt Lake area, there is a high rate of glaucoma. But among the Navajo, there is not a significant amount of just routine glaucoma. There is secondary glaucoma related to diabetes and trauma and things like that, but we haven't found a lot of just general primary open-angle glaucoma that we had anticipated. Especially one thing that's interesting too about there is a lot of diabetes, very prevalent, but we haven't found the manifestations, the phenotypes of diabetic retinopathy to be quite dramatic compared to, for example, the Latino population here in Salt Lake City.
And in that note, have you taken an epidemiological approach to sort of looking at the population and understanding how much of the population, you need to screen or get to or getting to ensure that you're, at least triaging most of the population and finding those at risk for diseases like all those people with diabetes?
Yeah. So long term, what we hope to do too, I didn't add this in the program because it's still in its preliminary stage. But yes, teleophthalmology, I think there was a question about teleophthalmology and in our use of teleophthalmology. We had a researcher here that was doing teleophthalmology diabetic visual screenings, but she left to New York, and so that program fizzled out. What we're hoping to do now is re-establish that program and using cameras that are deployed throughout the nation. So this will allow us to screen more patients, particularly those who don't have access to a clinic close by. And so that is our plan. In terms of conducting a study, for example, a rapid assessment of blindness, logistically, it's a bit challenging with our current volunteer base and our current staff. But we feel also, I think there's some debate about the utility of doing a rapid assessment of blindness here in the Navajo Nation, that it might be better to employ newer tools to conduct a new kind of modern rapid assessment of blindness using non-mydriatic cameras. So we're thinking about that possibility. One of the programs that we're heavily involved in right now in Salt Lake City is a local teleophthalmology program with our FQHC. So the lessons that we learned from that, we're hoping to deploy when we're down in the Navajo Nation in the future.
And that brings up the question I had on your screening. So what does the screening protocol look like? Do you use imaging devices in that screening?
Currently, we do not use imaging. It's just visual acuity, and patients will come through history after their history is taken. And if we feel that those patients need to be dilated, then we'll do a full complete dilate exam. So we have staff available to do complete exams at the time of the screening. But for patients that are low risk, deemed to be low risk, healthy otherwise, and maybe just have refractive error, then we don't do a complete full dilated exam. But we certainly encourage those patients to see the local optometrist that's employed by UNHS for their annual full exams.
And now that you have Medicaid reimbursement, is there any ideas of starting a clinic locally or training even those in the Navajo Nation over time, many years probably, to provide such care?
Yeah, I think largely it will be based on technical support that we could use. If we could train super techs throughout the Navajo Nation to do the screening and to also take the fundus photos, that would go a long way in terms of identifying patients at risk who need acute care.
Jennifer Leo had a specific question on the vitamin A deficiency research. Is there a timeline for that project or is it ongoing?
It's just starting. We've just got IRB approval from the Navajo Nation. The Navajo Nation has a separate IRB. And so in order to conduct research on the Navajo Nation, those of you that are familiar with conducting research with other indigenous populations, there's usually a very strong oversight a lot of oversight that's involved in this particularly protected populations. And so we've had to get IRB approval through the University of Utah and the Navajo Nation. So those are secured now. And now we're in the logistical phase of when we're planning on doing the screenings, because this will require phlebotomists to go down and actually draw the blood samples, as well as do the as well as do the Vegemeter levels as well.
A lot of logistics involved in that, and even
Right.
in your program now. Do you find that there's a fatigue of volunteer fatigue in sort of doing this, or is there's always enthusiasm and new people coming?
Yeah, we often have a wait list for volunteers for these trips. So it's only 5 or 6 trips a year as well. We have a certain season when we can travel safely down the Navajo Nation. Typically between the months of November and February, we don't travel because we do have to cross a high mountain pass to get there. And the weather can be quite dramatic and dangerous. And so those are the times when we don't go down. So typically our season starts in March and goes to the end of summer, early fall.
And so in doing all of this and looking at this as an example of a healthcare delivery model that may work from an underserved community, although your distances may be further out to the Navajo Nation and more rural, how do you translate this to something that may be more local, like in underserved urban areas in Utah and in Salt Lake City when you're doing it kind of locally?
Yeah, great question. So we've partnered with the Urban Indian Center. And the Urban Indian Center serves not just the Navajo only, but all indigenous patients in this region in Salt Lake area. But they also are willing to see other patients too who are uninsured or underinsured. And what we've done now with the Utah Urban Indian Center is to create a pathway where we can actually dual employ an optometrist. So Urban Indian Center has decided that they need to have an optometrist on site. And we as the Moran feel like we need to have an optometrist to help navigate our outreach program or to help administer our local outreach program here in Salt Lake City. So this will be a duly funded position, both paid by the University of Utah and the Urban Indian Center to employ an optometrist at their clinic site here in Salt Lake City. And our optometrist there will help with our co-management and also help to conduct regular eye exams and screening and also prepare patients for specialty care. So among those patients that need diabetic care or AMD treatment, for example, the staff optometrist, along with his technical staff, will help to gather the images that are needed in order for patients who get regular injections, for example. So that work is translating in terms of finding local partnerships and being able to continue that work here local, even more closely here in Salt Lake City.
Good. And Raheem has a question along his own lines of work being done globally, using use of AI assisted imaging technology, diagnostic imaging in screening. Any thoughts of doing that or plans of doing that?
Yes, absolutely. I think one of the challenges with all AI systems is it needs to be locally built. The database needs to be locally built on the particular population that you're looking at. So we'll have one developed here, particularly for Salt Lake City, in terms of the wide demographics that we see here in Salt Lake City. And then, yes, the long-term plan would be to do that for our work down on the Navajo Nation as well.
Great. A lot of great discussion around this. Definitely area of need, within our own borders of the United States, and really trying to address this with a lot of learnings that we've had from international experiences, trying to apply them locally here. But it's very nice that you have partnerships, and that's one of the things. Like, how do we involve the local folks who are trying to help in helping themselves, like in the process of being screeners, being advocates? Is there any kind of championing that's going on, or any lessons that you can help share with all of us about how you're doing that?
We haven't done that to a large degree. We've thought about it. Salt Lake City is a refugee resettlement city, and there are just many different groups here represented throughout the world. Recently, we received a large Afghani population after the pullout. And so one of the programs that we thought about having is, particularly because the young people tend to be representatives and ambassadors and liaisons for their elders in their community, is starting kind of a high school-based program for some of these new Americans that have arrived to be kind of vision ambassadors for their community, to be able to provide some of the basic education in terms of eye care and eye health, and to help them navigate. It's a very complicated system, as we all know and live in. The Utah or the United States healthcare system is very complex, and it's not any different here locally in Utah. And so fortunately, we do have refugee resettlement agencies here, International Rescue Committee, South Asian Community Services, and Catholic Community Services that provide a lot of those services to help navigate the healthcare system, but it can still be often challenging. So we thought about developing a high school-based program for some of these new Americans to be able to provide that mouthpiece and to be able to be that liaison to help their communities navigate the healthcare system in general.
And if you find people who need further care, right? How do you go about managing that cost of care for them, or what kind of aids are there for them to kind of continue their care if they need complex surgery or further advanced care?
Yes, particularly for the Navajo Nation
Yeah.
patients, we bring them up here to Salt Lake City. That's what we can do. Locally, we have an apartment that we have rented out throughout the entire year that we use for our outreach program. That apartment is used both for patients periodically and also for observers that come into our observer program. And so we have the ability to be able to house them here. In terms of the funding, it's all donor-based currently. As we become more financially independent of our donors, our hope is that our Medicaid funding that we receive from our screening and from our exams will help to provide kind of a bank available to be able to use to fund care if needed. Some of these patients do have insurance, and so if they do have insurance, we're happy to use their insurance and bill their insurance. But for those that do not, we will still rely on grants and some of our work that we do through Medicaid to fund that.
Okay. Any other questions for Craig on his work here? All right. Well, Bob, did you have a presentation that you wanted to make on the pediatric?
I do. Yeah, I'd like to talk a little bit about our pediatric programs, and apparently, Craig, are you still sharing? Because it says that somebody's sharing and I cannot share my screen.
Yeah, I'm done. I think
okay. And so let me this right here. So hopefully you can hear me. We had some issues with the audio. I've been involved since 2013 at the outset with our pediatric outreach on the Navajo Nation. And the way this did, kind of got going, the way a lot of things happen is that somebody knows somebody and they ask them to do something. In this case, our first administrative director of outreach, a guy named Michael Ye, had been a middle school principal, and the school he worked at had been part of a program called the Navajo Santa Project that took supplies and gifts down to the Navajo Nation at the holidays. And they asked him, when they knew he was at the Moran Eye Center, if we would get involved. And I think that is really how things came to pass with our program. I don't have any financial interest. This little guy, and most of the really cool pictures that Craig showed and the ones that I have were taken by a photographer, Michael Schoenfeld, that I need to acknowledge. This little guy is one of the reasons that I'm still involved in this and go down regularly. And the kids there definitely need care, and it's very it's fun to deal with them. I've been going down about 5 times a year from 2013. It is about a 5 to 6 hour drive from Salt Lake City. We typically have a pediatric team leave on Thursday, late in the day, or we have the option of flying down with the surgical team on Friday morning, depending on my schedule on Thursday. We do a clinic at one of the San Juan School District schools on the Navajo Nation on Friday, and then we do a joint adult pediatric clinic at a UNHS center on Saturday. And as Dr. Chaya mentioned, I often stick around to take people hiking, biking. We've also done a river trip on the Colorado River when one of our volunteers had been a professional river guide. We register patients, try to get demographic identifying data into our EMR, and then we obtain consent, hopefully ahead of time, from parents to examine the patients and dilate pupils for the examination if needed. And then we get family contact information for follow-up. Now, some of you may know Eliza Barnwell. She was at the Global Summit. She's now at the Storm Eye Institute. She went down as a volunteer with us to Navajo, and here she is measuring distances for visual acuity testing. We do measure visual acuity and try to do it as accurately as possible using either Leah figures or HOTV charts. We also use the spot vision screener, and we use that mainly for the younger or pre-verbal or terribly frightened children. We get a history, we check motility in pupils, and we put in dilating drops. And all of the refractions that we do in the kids are done under cycloplegia. A decision is made by my orthoptist, Julie Harmon, who puts together the visual acuity data. She checks motility and makes a decision about whether they pass their screening or they are dilated for further examination. While they're dilated, we tend to entertain them, either coloring, playing games. Here is Eileen Wong. When she was a resident, she's currently our pediatric retina specialist. And this is in the school library, a common site of examinations at the elementary school in Bluff, Utah. Retinoscopy, if you make it fun, kids will interact with you. And I love these Luno skioscopy racks. I have no interest in the company, but there are no sharp edges to poke kids with if they decide that they want to suddenly depart during the examination. It's a great opportunity to teach residents retinoscopy. Many of our residents have gone to the Navajo Nation with us. This is Julia Bird. She went on to do a pediatric ophthalmology fellowship at Children's Hospital in DC with Mohammed Jafar, and is currently practicing in Florida. And she did, high volume retinoscopy paired with me on our Navajo Nation trips, and went when she was a second and third year resident, I believe, on every single trip that we went on to see kids. I think Dr. Chaya showed you this picture of our team. And this is everybody excited, getting up in the air prior to leaving on an adventure. These next two photographs are actually not from the Navajo Nation. They're from Chuuk, Micronesia. And Dr. Chaya talked me into doing a pediatric screening trip there, just to show that if you have 2 folding chairs and at least some decreased lighting, you can do retinoscopy. you can do an anterior segment, a fundus exam on kids, and really do a pretty good job of taking care of them. When kids need glasses, we learned early on that when we gave out glasses prescriptions, they often were not filled. There are a lot of logistical issues I'll talk about in a bit with that. We now provide all the glasses. We have volunteers come down who are trained to some extent to function to gather the data that the opticians need to make lenses and to fit them in frames. They help the kids pick out frames, and then they adjust them as best they can. That frame is then packaged for that child, and we deliver them on our next trip down using Native American volunteers through the local UNHS health centers to get those glasses to the children. We're currently working trying to get screening done in the chapter houses. The chapter houses turn out to be the place that the preschools live. We currently do not have access to screen preschool children on the Navajo Nation. We get to see wonderful views. This is on the drive out to Navajo Mountain, which we access by going down to Kayenta, Arizona, and driving a long ways to get to this school that crosses back over the border into Utah. And these are some of the dwellings. When you see these dwellings, keep in mind that many people live on the Navajo Nation without electricity, without running water, without flush toilets. In the past, post-World War II area, many of these dwellings were made using the debris that was left from uranium mining, which had very predictable outcomes, unfortunately, in terms of the incidence of cancers in the Navajo people. Now, we presented our just preliminary pediatric astigmatism data, and this is very busy. This is a poster that was presented at the APOS Pediatric Ophthalmology meeting in New York a year ago by Ryan Wallace and Jenna Jensen, both medical students at the time. Ryan is now an ophthalmology resident at Baylor, and Dr. Jensen has started as a resident with us. Both of them do plan to continue their outreach efforts as part of whatever practice they choose in the future from my conversations with them. And, you know, what we wanted to show was a follow-up to data that was originally published by Joe Miller and Velma Dobson. Velma is a vision researcher. She is the force behind the Teller Acuity cards when she was Dr. Teller's graduate student, and was also vision researcher behind a lot of what we accomplished in the cryoretinopathy prematurity study papers. She moved to Tucson, and she and Joe Miller collaborated to do a project looking at astigmatism in their Southwestern Native American population and identified large amounts of astigmatism. Astigmatism has been shown in published studies to affect academic performance. And so we wanted to look at this and see where we were. And all of the children in this study, and they're 5 to 17 because those were the school age kids that we have had access to, I personally examined each and every one of these children. Most of their data was recorded on paper charts due to issues with lack of internet access, particularly at the schools, to get the information into an EMR, but we're changing that. We did record all of this data, and then all of those paper records were manually entered by Dr. Wallace and Dr. Jensen into our EMR. This is the data mean cylinder by age, and basically, you know, shows that there were significant amounts of astigmatism in almost a third of these patients. Had over 2 diopters of astigmatism uncorrected. About a quarter of our patients came in wearing glasses, and many of them had worn glasses but did not have them when they came in. And what you see here is that about 15% of the kids had visual acuity in the moderately visually impaired category, and about 35% in the mild. And this is a graphic representing that. The blue is the pre-correction incidence of the mild and moderate visual impairment, and then post. And one of our goals going forward is to decrease the red that you see on this graph. And I'm particularly interested in where we would be with the younger kids. We do not have this stratified by age. These are those references that I mentioned. Now, what logistics and challenges do we have? Dr. Chaya mentioned, the fact that the Navajo Nation is to some extent a job and food desert. If you look at the job boards at the chapter houses, most of the jobs involve working either at one of the hotels on the Navajo Nation and not running the hotel, but doing other jobs. They have to drive hours to find fresh vegetables for their children. And they have to drive long distances, in part because of the poorer roads. Many of them drive hours on dirt roads to obtain health care. They do have 2 employed optometrists, but there are no ophthalmologists practicing on the Navajo Nation. Children are often not accompanied by family for school exams, and parents are often not present when we see them on the Saturday UNHS eye clinics. I did initially give prescriptions, and we saw kids come back again and again, not having had them filled, and we decided to change that. So now we provide the glasses, and we plan to continue that. It would be nice if we had some reimbursement for that through Medicaid to offset the expenses for the frames. And for some children, it's necessary to have a separate pair of glasses at school because they never make it from home to school. We're working on the internet access issues. Now, in the future, we're going to coordinate better with UNHS regarding our interaction with the employed optometrists to better dovetail what we're doing with their practice efforts. Dr. Chaya mentioned, having them see post-ops, and I want to get them involved so we're not duplicating efforts in terms of trying to screen children. We are going to train local healthcare workers to get into the preschools, and we're going to explore better options for communication between the clinics, the care providers, parents, and the teachers to make certain that all of the children on the reservation have access to eye care, not those that are closely allied with the clinics. I want to get better age-specific outcome data, and I want to promote an interest in eye health careers. And the plan to do that at present is to have our interested technicians, hopefully optometrists, me as well, go into the high schools when we are down there on a Friday afternoon and talk to the kids and try to let them know that, yes, this is an option for them and it's one that they should consider. There are good medical school programs for Native Americans. We don't have one at the moment at the University of Utah. There is an excellent one at the University of North Dakota, and I have been involved in talks with our medical school administration about trying to change that. Another one of Michael Schoenfeld's photos, that in a nutshell is what we've done with the pediatric program and with Dr. Chaya with our adult program. Our hope is to continue this. I think that, based on the efforts of our technicians and volunteers, I mean, we've made this sustainable to be able to go down and do what we're doing, what we want to do, what we do better, and provide better care to these kids. And that's one of my interests as I get ready to head off into retirement, is to stay active in this and to be involved in it. And that's really all I have to say. I'd love to entertain any questions that you have.
That's an excellent overview and long history there that you've provided us. This is great. I'd like the chat use of questions. Any questions for Bob here on Dr. Hoffman on his work? And I'd love to see all the trainees that have gone through the process. It's one of the questions, are trainees engaged and how they continue? And it's amazing, Bob, that you've kept in touch or you've tracked all your students, where they're going, all your residents. So that shows the sign of a very great educator and a very caring teacher. So this is great.
But it's fun to watch them grow up, Rajiv. They come to us, and I've known some of these folks, since they were undergraduate students and came and expressed an interest and wanted to hang out in my clinic. And now I see them in their practice careers, and it is encouraging. I watched Dr. Chaya come hang out with us as a Alan Crandall's fellow. He's in charge now, and I'm proud of him. It's good.
Great. No, that shows the longevity of programs. I think both John Barrows and Raheem probably tell you their work too is just involving people in the process, and then even Jorge talked about are they trained? Are they trainees or part of your program? Do you grow your program by the outreach that you do, not only amongst the people you're helping, but also the volunteers that come in? And I think that's really, really important for sustainability and for growth of the program.
We've found both in our local, regional, and our international programs that you absolutely have to demonstrate an interest in ongoing interaction with people, or you're just wasting your time. Going and doing good deeds and leaving doesn't get the job done. And it took a number of trips going down to the Navajo Nation before they realized that we weren't just going to go away like other folks had, that we were going to keep coming back. We've all made friends among the administrators, the techs, the liaisons we have, and we have patients now that come to visit us. And if they can't get in to see us down there, they'll drive to Salt Lake City. And I'm here to tell you it's a long trip. And, they come visit us here. So I'm encouraged. I'm proud of our program, but I also feel strongly that we have a lot of work to do.
That relationship is so key. We talk about just providing healthcare and look at the diseases that we're helping or the vision that we're saving, but it's the personal connection, the heart-to-heart connection that is so important in anything we do, whether it be in our backyard or across the world. So I'm really glad that that's being maintained. Dr. Brings had a question on eyeglass funding through Medicaid. Is that something that you've been working on, and how is that process going?
We have not worked on that specifically. We're working on getting Medicaid funding to cover some of the patient care first, and then we'll work on the eyeglass coverage. At present, we are counting on the benevolence of companies making lenses for us, and we use donor funds to take care of the $10 fee for each frame that we dispense.
And is there any tracking of in the glasses distribution that you're doing? Do you have a track of how many glasses you're giving out, or whether they're reaching the people and they're being used, anything like that?
Well, we see the kids that come back with them, but otherwise, no, we don't have anybody directly following up on that. I think it's a wonderful idea. Right now, what we're trying to do is to get the glasses, on the children, and help them do better with school. I worry about even the older kids and their ability to drive. Getting back to the younger kids, those kids, the kids that are in the amblyogenic range, if they've got bilateral refractive amblyopia due to large amounts of uncorrected cylinder, those are the kids that I think they're going to benefit the most and have the near normal vision if we're able to keep glasses on them. The one way I try to tinker with this is I bring them back in for follow-up. They know that I'm going to be down there during the non-snowy, non-summer, because the kids aren't in school months. And we have a team down there every month looking at kids, and they check with the clinics, and they come in to see us. Now that doesn't help the kids. And I still fear that there are many kids in outer reaches of the Utah part of the Navajo Nation that we're not seeing. And that's where I'm depending on our local, volunteers and health workers through UNHS to try to help us reach those kids so that we can get them in.
And so do you have a sense of that? So, I've talked about this epidemiological approach, right? Do you know like how many new kids or new children are coming to the system versus how many just return, so that that you're kind of funneling like new populations or reaching out to new folks over time?
We don't have definite numbers on that. I have a meeting set up next week to meet with Brian Stagg, who is our kind of big data researcher, in addition to being one of our glaucoma specialists. he and Afua Sari, she presented at the Global Summit. Afua is working with us here doing public health research. And she and Brian and I are going to sit down and try to brainstorm about different projects. And one of the things that we're going to talk about is how to try to track who we're seeing, who we're not seeing. And so we'll have that data in the future, but I do not have it now.
Sounds good. And Craig, maybe you can help answer this. Do you have any idea of how many adult glasses you're giving out to folks?
I just put it in the chat. My best guess is roughly between 300 to 400 pairs, but that includes prescription and just over-the-counter readers. Some patients are just coming in to get readers, so that's a general ballpark.
I would guess, Rajiv, that about 2/3 of the kids that we see for exam wind up in glasses at some point. That's a lot. And it's much higher than any other population that we see here in Salt Lake.
Right. Well, we've been seeing, we started this here locally in upstate New York, and our inner city population has higher rates of myopia than the suburban population do. So it's interesting, if you find some similar trends there of myopia and or other eye diseases more prevalent in that population.
It's interesting to me that it's myopia and astigmatism, not hyperopia.
Yeah.
And almost all of the refractive amblyopia is, we'll see a child who's -8 +6 at 90. They're not in glasses. And, it's really gratifying to put those kids in glasses. But the other thing that's interesting is the strabismus that we see is almost all intermittent exotropia, not infantile esotropia or accommodative esotropia. Those are all things, sideline issues that I want to get into. The incidence of strabismus on the Navajo Nation is actually low. It is not, and so there are not many surgical cases, pediatric cases that come out of our Navajo clinics. Those that do, because of issues with concerns about pediatric anesthesia in the local hospital in Blanding, Utah, where the adult cataract surgery is done, I bring the children up here, so we have access to our pediatric anesthesia services at the Children's Hospital.
And in your outreach to children, is there any policies on school screening in the Navajo Nation about screening kids at certain age groups or grades?
They try to screen every grade every year, realizing that school nurses there are spread few and far between, but they are absolutely wonderful, and I'm dependent on them. They come to each and every one of our school clinics. They have a list of kids that they're worried about, that the teachers are worried about, or the parent or healthcare provider has concerns about, to make certain that I know that when I see the kids. So the interaction with the school nurses is key. They've been really helpful. They're trying to screen everybody that they can, but it is difficult. And we try to visit every school on the Utah portion of the Navajo Nation at least once a year.
That's a kind of data-driven approach, is sort of, making sure that you're getting to the most people you can. I think that's very, very important. So in the last couple of minutes here, this is a program, happening in one area of the country, but has a lot of relevance to what's happening all over the United States as well as the world. What are your challenges? Do you think your top 3 challenges, and how do you think that the country should come together to sort of understand how do we address them?
I would, from my perspective, the key issue is to identify the areas of need, and then enlist interested local people whenever possible to help deal with them, to help them take that as their personal mission to help those patients, whether it be an inner city, urban population, or on a Native American reservation, to say, that's my problem, I need to deal with that.
It's very, very
I think, starting a discussion on how to deal with this overall, to have coordinated approaches, is probably much better as well.
we're trying to see how to marry, Dean's work with epidemiology, especially like his work in Ohio, to look at seeing, the populations at risk, and then kind of targeting our outreach and as an example for more focused and data-driven sort of care, and making sure that we're trying to get to the most people as we can. And this is a work I know that IEF and others involved globally have been doing as well. So it's just sort of how do we take a more conscious effort to build systems that are not only sustainable, but also impactful, and kind of measuring the impact over time. So, but it's wonderful that the enthusiasm and the volunteerism that you've gotten, the sustainability you've gotten, the program growth just speaks for itself, and the amount of kids you've received. What does the Navajo Nation think of all of this? And we don't have them on the call here, but have you received feedback from the nation?
Oh, they are overwhelmingly grateful, for what we're doing, and want us to keep coming down. And I've, spoken to many Navajo that I know at the clinics, and their administrator, Mike Jensen, and his staff have been very helpful. And whenever an issue comes up, they are always happy to sit down and discuss it and try to help make things better. And they want to, work with us. So it's been a very positive interaction. Dr. Chaya has gone down, when to Shiprock, to the headquarters of the Navajo Nation, to get IRB approval for the projects that we've done, and he's had very good, reception there as well.
That's great. Well, it's up to the hour now, so thank you so much for this discussion. Our next meeting will be on the 20th of September, where we have the folks from NORC talking about the Vision Eye Health Surveillance System, and we'll hear from the CDC in October. So I hope you join on those 2 months. So thanks all for joining, and thanks again for Craig and Bob for your great presentation. It's wonderful.
Thanks for letting us talk.
Thank
Have
you.
a good day.
Take care.
Great, thanks.